Hi, Adult Health 2. This is the hematological disorder module. It's module 3. Uh, Readings are chapter 33 and 34. 33 just kind of goes over all the blood components and whatnot. So we'll kind of cover that, but really that is review. So if you're feeling like you need to kind of re-go over that, feel free. Obviously, not going to hurt, but we're not going to cover that too extensively with this. So blood components, we're going to start with bone marrow. Just remember bone marrow is primary site for blood formation and maturation, and that's called hematopoiesis. So that's a really great vocabulary word for us, right? Hematopoiesis. That just means blood blood maturation, right? Red blood cells, WBCs, all the things. So it is the bone marrow involved in the body's immune responses. It's considered an organ, which is kind of cool. And it's one of the largest organs. It takes up 4 to 5% of total body weight. Okay. So that's, I mean, I never think of bone marrow as an organ. So, but there you go. Just remember it's connective tissue. It produces stem cells. Stem cells are the ones that are immature cells. They're undifferentiated, meaning they haven't been given a purpose in life yet, right? They're just there ready to be told what to become. So they can become all sorts of stuff. Um, Let's see. Flipping through all of this. Blah, 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 right? Erythrocytes. Remember, erythrocytes are our red blood cells, okay? Red blood cells, most abundant of the formed elements. Hematocrit is the volume of red blood cells in the blood. So hematocrit is how much of our blood is made up of RBCs, all right? And then hemoglobin is the O2 carrying portion of RBCs, all right? So that's why we look at H and H, hematocrit and hemoglobin, because we want to know how many, how proportionally speaking, how many red blood cells we have, not how many, because it doesn't give us a number, but volume of RBCs. And then what kind of hemoglobin do we have going on? Because hemoglobin is what transports our O2. And if we have a low hemoglobin, then we're going to have a low O2 carrying capacity. Heme, heme of the hemoglobin, has iron at its center, and iron is what binds to O2. So when we are talking about anemias, a lot of times the most prevalent one is iron deficiency, right? And so that's if I have if I'm deficient in iron, okay, and iron is what binds to O2, then my problem is my body is not able to transport enough O2 to keep my body happy. Okay. So that's why we start talking about these blood components before we talk about anemias, because you have to understand what these blood components do and how they affect then, if they're low, what's going on in the body. And that is going to direct what signs and symptoms you see related to these different anemias. All right. So slide number 6 here, our leukocytes, our WBCs, we know those are involved in infection fighting. Um, there's all different ones. We've learned that pretty extensively at this point. And then we have slide 7, platelets and plasma. Platelets or thrombocytes. Okay, these are really cool. Platelets are circulating cell fragments. They are what start to form your clot or your fibrin. Okay, fibrin's kind of sticky, it clots together, it, keeps you from bleeding to death. Okay, so platelets, thrombocytes, circulating cell fragments. They are going to show up, form a clot made out of fibrin, very sticky, clumps together. Okay. Plasma. Plasma is just kind of a vehicle for everything to float around in. So it's a clear yellow protein. It makes up the blood. The RBCs, WBCs, platelets, they all float around in the plasma. It's kind of how everybody's able to get around. Plasma is 90% water, 8% protein, and then 2% just other whatever, right? So plasma is just our transport. So shout out to the spleen. We can't talk about blood and not talk about the spleen. Spleen is a lymphatic organ, so it's part of the lymphatic system. It filters, okay? The spleen is uh, just filtering all of our blood all the time. It actually goes through 2.5 to 3 liters of blood per minute. Think about the liter bags of saline, the 1,000 ml bags of saline that we hang, right? Think about how much fluid that is. The spleen does 2.5 to 3 liters of that per minute of blood filtering. That's a lot. So this matters because if something is wrong with our spleen, we're going to have problems filtering our blood, and that's going to end up in bigger problems. And I can tell you from experience, the people we saw with like splenectomies and whatnot were motorcycle vehicle accidents. And I don't know if it's the way people hit the handlebars or, how they land. I honestly, I don't know what the deal is, but motorcycle accidents, we ended up with more motorcycle accidents with people having splenectomies or damage to the spleen where stuff wasn't functioning, and it just affects the rest of the blood, which obviously affects everything else, right? So in the spleen, the red pulp filters, okay, and then the white pulp, oh, I see a spelling error, I'm sorry. The wit pulp, according to the slide, but it's white pulp, is involved in immune function. So just remember that the spleen does a lot related to keeping our blood healthy, flowing. It actually filters out, our body produces cancerous cells all the time, right? Um, and the spleen filters those all day long, 24/7. That's what it does. And so just remember, if something happens to your spleen or there's some sort of dysfunction, we're going to end up with lifelong chronic problems related to that. So here's a picture of plasma. Okay, it just kind of, I like the diagram where it shows the plasma all sorted out. Where and what makes up our blood: 55% plasma, 1% WBCs and some platelets, and then 45% RBCs. And then it also shows the plasma breakdown. So that's just kind of a nice little slide. So clotting cascade. Clotting cascade gives me PTSD, back to nursing school. We just know that we have an intrinsic cascade and an extrinsic cascade. The extrinsic cascade is faster. Okay, it bypasses some of the steps in the intrinsic cascade. The intrinsic cascade, when we get a PTT, we are looking at the clotting related to the intrinsic pathway. All right. When we look at an extrinsic pathway, we measure that by a PT. All right. So clotting cascade, it's triggered by the formation of a platelet plug. Basically, the body realizes that there's some sort of risk of bleeding, forms a clot, platelets form a clot, and then it triggers all these enzymes or proteins that tell the body then what to do further about it. And it's just a cascade. This triggers that, blah, 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 all the way down. Figure 33.12 in your book has a picture of the clotting cascades. All right. So just take a look at that. We're not going to go over it. You don't have to memorize every single part of the clotting cascade. Just know that there's intrinsic and extrinsic. And extrinsic faster bypasses some of the steps of the intrinsic. All right. Labs we look at related to blood, CBC, complete blood count. I care about my H&H. I care about my RBCs. I care about my MCV. MCV simply tells you how big your RBCs are. And the reason we care is because we have macrocytic diseases, which means stuff is bigger than it should be. Those cells are bigger, they're macrocytic. And we have microcytic diseases, meaning those red blood cells are smaller than they should be. And if they're smaller than they should be, then I'm not carrying, especially the O2, that I should be, right? And we know that anytime the body is hypoxic, it doesn't love that. So MCV is just how big my RBCs are. All right. And then of course, when we're talking our CBC, I would like a CBC with a differential with a diff, because I want to know what those WBCs are up to. I care about if you, we haven't talked about this in Adult Health 2 yet, but we did talk about it in Adult Health 1. If you remember, we have bands with WBCs. Bands are just those immature white blood cells. And if we see that the body has a high level of bands, that means that the body is fighting something, didn't think it even had time to differentiate those WBCs, and is just throwing out these baby white blood cells because it's like, we need more white blood cells and I don't have time to make these into something specific. So I'm just going to throw out these baby white blood cells. So that's what bands are. That's also called a shift to the left, if you remember. So just put that back in your brains. This is box 33.1. This is a good one to look at. This is a bunch of medications that can increase risk of bleeding. So we definitely care about this. And some of these are very common meds, right? None of these are crazy. And of course, we know about our like anticoagulants, heparin, we know about NSAIDs. But there's some other ones on here. So take a look at this, box 33.1. This is your clotting studies, slide 13. This is something you're going to want to have in your brain. So prothrombin time, or PT. This is what we use when our person is on warfarin or Coumadin. All right. This is an extrinsic coag pathway. So extrinsic because I'm giving somebody something that's not part of the body. I'm giving you warfarin or Coumadin to affect your clotting cascade, right? So it's extrinsic. There's an outside factor playing into how the body is clotting versus intrinsic, which is all just the body's stuff. Okay, it's just the body's natural clotting cascade. Extrinsic means I'm introducing something from the outside, and that would be warfarin or Coumadin in this instance. So we use PT to measure how that anticoag therapy is working. Bleeding time tests overall hemostatic function, how well you clot, right? Because we know that healthy people should clot in a certain manner in a certain amount of time, right? Your body should not like let you almost bleed out before it decides to clot. So we measure the bleeding time. INR is a measurement of PT. INR is a measurement of prothrombin time. Your lab is going to convert your PT to an INR. We usually want an INR between 2 to 3 to be therapeutic. When we talk about these clotting studies, when we read the results, we say it's therapeutic or non-therapeutic. All that means is it's doing what it's supposed to, or it's not doing what it's supposed to. It's helping or it's not helping. Okay. So therapeutic or non-therapeutic. INR therapeutic level is 2 to 3. I know you guys don't have to memorize results, but really INR, it's not that tough, and you use it a lot, right? You're going to look at an INR in pretty much everybody. So now we move on to a PTT or an APTT, same deal. This is looking at heparin. This is an intrinsic pathway measurement. Heparin's part of the body. Okay, heparin's part of the clotting cascade. So this is considered intrinsic. So PTT, APTT, heparin. All right. Platelet aggregation. That just looks at how your platelets are clotting. Are they clotting or not? Clumping or not clumping, right? Platelet aggregation. How are they gathering together? Right? We see this with some chronic diseases like von Willebrand's. I've never run into von Willebrand's in real life. I've heard of it, never seen it. But we also may look at this related to like aspirin, NSAIDs, anti-neoplastics, and some psychotropics. Tropics. I want to know how they are affecting how you clot. Okay, so that is why we care. Bone marrow and aspiration biopsy. So we're going to use a bone marrow aspiration, probably biopsy with it. When we're talking like our thrombocytopenias, our leukemias, maybe some tumors, if we have some crazy infection going on, we could actually use a bone marrow aspiration and biopsy. So they go into the bone marrow and actually remove some of the fluid and then biopsy it. Okay. Uh, RN considerations, patient education, right? Local anesthetic. Um, the procedure itself only takes about 5 to 10 minutes, but I am using a needle to go into the bone marrow. So I'm going to be worried about leakage afterwards. So we're going to be applying direct pressure. Um, we want our person to know when to contact the physician, which is really going to be related to signs and symptoms of infection. And then we need to make sure that that specimen gets to where it needs to go, right? We transport that to pathology. Slide number 15 here is figure 33.14 out of the book. Just gives you a little bit of a picture, little bit bigger explanation about your bone marrow biopsy. All right, now we are moving on to chapter 34, hematological disorders. So here's our slide again about blood. Just remember that blood circulates oxygen, nutrients, hormones, metabolic waste. It's getting everything where it needs to go. So in general here, anemia is associated with a low red blood cell count, low hemoglobin concentration. It could be one or the other, actually. It doesn't always have to be both. So we could have low red blood cells, or just low hemoglobin concentration, or both. So what happens is we end up with reduced oxygen carrying capacity and decreased perfusion, right? So erythrocytes are RBCs. They pick up O2 from the lungs, carry it out to the tissues, make sure our tissues stay nice and oxygenated. And they also pick up CO2 from the tissues, take it back to the lungs where we expel the CO2, right? So really, you can't underestimate how important, we always talk about the lungs as far as O2 and CO2 exchange, right? And breathing. But we need the red blood cells to perpetuate that process, right? How does the CO2 get back to the lungs where we can expel it? How does the O2 get to the tissues, right? If it wasn't for the red blood cells, all of that would just sit and we would die, okay? So that's why our red blood cells, you just can't underestimate how important they are to the respiratory process, to breathing, to living, okay? So next slide, shout out to the RBC. Like we talked about, most abundant of the formed elements. RBCs are super fun because they're so flexible. And remember, we not only have capillaries, but we have microcapillaries. So these are so teeny tiny, and those red blood cells are so flexible, they can just squeeze right into the end of all those teeny tiny capillaries. They can just get in there. They live for about 120 days. They mature in the bone marrow, and then we depend on that spleen to filter out all those old RBCs. Okay. Hematocrit is our volume. Hemoglobin is our O2 carrying capacity. The problem is RBC deficiency can be fatal within minutes due to lack of O2. Okay. So it's a big deal. When we talk about our people hemorrhaging, think about the fact that, okay, we're losing all this blood. We know that's not good. But in losing all that blood, you are losing O2 carrying capacity. So you're gonna go hypoxic. And that's not just about the lungs. That's about all the functioning tissues and organs. So what causes anemia? Blood loss, obviously, hemorrhage, inadequate RBC production, increased RBC destruction. So that could be like an autoimmune deficiency or situation. Deficiency of necessary components. We need stuff like folic acid, iron, erythropoietin, and B12 to make healthy RBCs. And so if we're deficient in any of those things, our RBCs are not going to be happy. Iron deficiency is the most common. Anemia risk factors. Again, acute or chronic blood loss, right? No brainer there. Rapid metabolic activity, meaning I'm using up those RBCs maybe faster than that 120 days, or I'm destroying healthy RBCs, whatever that may be. Increased hemolysis. Hemolysis refers to the destruction of red blood cells. Lyses is when they explode apart, bust apart. So increased hemolysis, destruction of RBCs, inadequate dietary intake or malabsorption. So maybe I am getting enough iron, but my body is not able to use it. Okay. So that's why we talk about malabsorption, because maybe you're getting enough, but your body's not able to process it. Okay, so that can be a problem as well. And then bone marrow suppression, anything that causes the bone marrow to not be doing bone marrow things, that's going to affect our RBCs. And then age, here we go again. As you get older, stuff's just not working the way it should. We're prepping to die. So age is always a factor. Clinical signs and symptoms, just in general. Mild cases may actually have no symptoms. We may not be aware until we go and get our blood done. Pallor, skin is going to look kind of pale. Think vampires, right? They're always pale. Fatigue, you're just tired. You don't have enough O2 floating around. Dyspnea on exertion, so just kind of short of breath when maybe you shouldn't be. Sensitivity to cold, tachycardia, the heart is working faster, and then dizziness and syncope. That can be related to like a hypovolemic situation as well. Also, the hypoxic situation can cause dizziness and syncope. So nursing interventions related to anemias. We're going to start with dietary intake. If you're low in iron, increase your iron, right? That's easy enough. We talk about that all the time. We're going to look at our vitals, in particular O2, because if I have low hemoglobin, I could have hypoxia that, I'm able to see on the finger, like what are you saturating at? um, we may give you meds to help with absorption. And then our education is really going to be related to dietary intake, meds, when to take them, what to look for, all of that stuff. Complications related to anemia, it can be really dire. I mean, heart failure, renal failure, impaired thermoregulation, meaning that, your body's not able to maintain a good temperature, obviously impaired immune function, and then psychomotor sort of and cognitive impairment. This affects your brain. Your brain needs good blood supply just as much as any other part of you. So psychomotor and cognitive is definitely a thing. All right, we are going to talk about iron deficiency anemia. This for sure is the most prevalent anemia that we see. Hypoxia, duh, obviously. Remember that iron is in the middle of the hemoglobin. Iron is what binds to the O2. So if we don't have enough iron, we're going to be hypoxic. One of the weirdo things, you do get some weirdo things with this, glossitis. See, if you look at this picture of the tongue, it's slide 25. The tongue gets like shiny. It is weird. You can get fissures in the corners of the mouth, so like breakdown, and then colonychia. 10,000% I'm saying that wrong. But it's where your nails get really brittle and fragile. You can see in this picture, they're not forming well. Your nails are pretty, I don't want to say tough, but rigid, right? The nails get very flexible. They're not pretty. They don't look nice. I'm trying to go backwards here. All right. So dietary and supplement considerations, patient education. Hold on. I think I skipped a slide. Maybe not. All right. If I skipped a slide, I'm sorry. I suspect it was slide 26. All right. So we're on slide 27. Dietary and supplement considerations, patient education. So there are some things. Obviously, our treatment for iron deficiency anemia is more iron. But there's some weirdo things related to iron intake that we need to consider. Drinking OJ or other citrus juices, so the acid with iron increases absorption, so that's good, right? But we don't want our person to be having tea with meals because that will decrease iron absorption. So let's say our person is dedicated to having like some spinach in a salad every meal, or is trying to eat more red meat, but they have tea with every meal. That is actually going to inhibit the iron absorption into the GI tract. So there's a lot of dietary things with this. Do not take your iron supplements with dairy products. Preferably, we want iron on an empty stomach. Also, one of the weirdo things that you see with iron deficiency is this pica, which is like craving for non-food items. Um, a lot of times, and this is so weird, but people will have a craving to eat dirt with iron deficiency anemia, and that is because there is iron in dirt. And it seems so weird that the brain or whatever would be telling our body to eat these things. But there is iron in dirt, and so, the body's trying to fix the problem. But the good thing is when we resolve that iron deficiency, the pica usually resolves. So we want to know our food sources: red meats, green leafy veggies, legumes, beets. All of those are really good food sources related to iron. And it's good to know that we don't just need red meat, because if our person is worried about cardiovascular stuff, cholesterol, whatever, they may not want to increase their red meat intake, but they still have the option of those green leaf. All right, so our patient education. So signs and symptoms to report immediately. Any sign of bleeding, right? We worry about that. And then we have, as always, increasing stuff. So increasing fatigue, increasing shortness of breath, anything that's indicating that the condition is getting worse. right? We would want our person to report that. So also, iron supplements can cause constipation. They can also cause diarrhea, nausea, vomiting, and just overall GI discomfort. So even though those are kind of expected signs and symptoms related to iron, we would want to tell our physician because, there's stuff the physician can do. Sometimes even just changing manufacturer can make a difference. Um, One of the weirdo things is dangers of lead exposure. So iron and lead occupy the same intestinal transporters. So if iron is low, you have a greater risk for lead to get into the system because those transporters are empty, right? So that is super crazy. And then prenatal teaching. We want our ladies who are thinking about getting pregnant or who are pregnant to make sure that their iron levels are up because it is important to the development of the baby. Um, oh, my slide doesn't want to move. Hold on. All right, so moving on to vitamin B12 anemia. B12, also called cobalamin. If you're not familiar, your Bs always have some other name, and so you may hear something being referenced as a deficiency, and it turns out it's actually a B vitamin, okay? So just be aware of that. So inadequate sources of vitamin B12, or like we talked about, you could have malabsorption disorders. So like you're getting enough B12, but your body can't utilize it. So one of the things to know, like the body stores iron, but the body does not store your B vitamins. So like if you take a B vitamin supplement, you'll notice your pee is going to be like highlighter yellow, right? And that's literally because you're kind of flushing out whatever the body has not utilized. Um, so we don't store bees, they're going to flush. So we have to have daily intake, okay? Also, B12, about 15 to 25% of older adults are B12 deficient. And that is related to gradual gastric atrophy and decrease in gastric acid production. And that is part of aging, but that results in your bees not being absorbed as efficiently as we need them to. So we kind of know that our older people, highly likely that they are deficient in the bees. So B12, it's just a coenzyme. It works in the central nervous system, helps form RBCs, synthesis and regulation of DNA. So it's important. Um, Vitamin B12 is also known as extrinsic factor. So we've got cobalamin, extrinsic factor, all of that refers to B12. We get B12 through animal proteins, so meat, seafood, eggs, and dairy. Um, let's see. Pernicious anemia is a B12 anemia. It's caused by the lack of intrinsic factor. Well, duh. Okay. Um, let's see. Pernicious anemia is an autoimmune disease that leads to a vitamin B12 deficiency because of the inability to absorb B12 without intrinsic factor. Okay, so let's see. B12 is important in the Krebs cycle, nervous system function. Looking through here, seeing all the important things. Sorry. I'm reading and talking. I don't want to overwhelm you with stuff that is just kind of interesting, but not necessary. We do worry about our long-term vegetarians and vegans. Also, lower socioeconomic status, right? Because maybe they don't have accessibility to the good fruits and vegetables and all of that we need for our bees. And that's a factor that we consider which with pretty much everything, right? And honestly, that applies to low socioeconomic, and then our vegans and vegetarians. We always think about, well, where are their nutritional elements really coming from, right? Are they getting all the things that they need? So risk factors with B12, what we just talked about, plus if you have like a GI resection, if you are an alcoholic, if you have AIDS, inflammatory bowel disease, anything that is affecting the GI related to absorption, okay, that's where our problem is going to come in. Also, if you have decreased acid secretions, so if you are on PPIs, H2 blockers, right, anything like that, acid aids in the absorption of B12. So when we reduce that GI acid, we are not going to be absorbing the B12. So there's our malabsorption issue. Okay. Manifestations. You can actually see spinal cord degeneration, peripheral neuropathy, altered mental status, including depression, and then Lermite sign. Lermite sign is like a spinal, like a shock that travels down the spine, from the neck to the spine. Okay. You can end up with numbness and tingling in the hands and feet, paresthesia, right? That's our terminology for that tingling. Um, and so Lermite sign is one of the big ones because there's not a whole lot that we see that related to. All right. Um, let's see. Diagnosis, history, physical labs, obviously. Our treatment, we're going to start talking prevention with people. They can do B12 injections. And then, of course, we always go to diet, right? We want to talk about where you can get diet, where you can get your B12 from, as well as supplementation. Bring into consideration those PPIs and H2 blockers. Um, so that's really our treatment. And and honestly, supplementation and foods is where we go with all of these anyway. Even the folic acid, the B9, anemia, same deal. Well, and the iron deficiency anemia, same deal, right? Supplementation and foods. Okay. So your dietary sources of B12, like we talked about, meat, seafood, eggs, and dairy. We do want you to supplement. Prenatal teaching. What's interesting is, so folic acid deficiency, folic acid is is B9. So B12 and B9 deficiency coexist a lot of times. So if I replace my folic acid, okay, with supplementation, if there is any, like, the signs, the typical signs and symptoms of anemia, those signs and symptoms may resolve. But what's interesting is if I don't replace my B12, neurodeterioration continues. Okay, so the B12 is what is related to neurodeterioration, my neuro signs and symptoms. Okay, whereas folic acid is kind of your typical stuff. This is sort of weird, but nitrous oxide inactivates B12 in the body. So I don't know if you've got a nitrous oxide like addiction, you may be B12 deficient, right? Um, Radiation for advanced cancers can also affect your B12. And then we talked about like acid reducing. Okay. Here's our folic acid. So patients at risk, everybody, nothing's really crazy on there. Older adults, chronic illness, ETOH, extreme diets, right? Because you're not getting the nutrition you need. Um, Methotrexate, dialysis, pregnancy, folic acid, I feel like we hear the most about folic acid related to pregnancy because it's so essential for the baby to develop. So I feel like that's where we hear the most about it. Like I said, folic acid is B9. So we do want to be able to distinguish between B12 and B9. They use the, hold on, let me look at my notes. We use the MMA. We test for MMA and homocysteine levels to differentiate between B12 and folic acid. With the MMA, so B12 converts MMA into a separate compound, a different compound. So if B12 is low, MMA is going to accumulate in the blood because if I don't have enough B12 to convert MMA, it's just going to continue to hang out as MMA. Same with homocysteine. Homocysteine is an amino acid, and B12 converts homocysteine into another compound. And if there's not enough B12, then MMA and homocysteine just hanging out being themselves. They have not been converted. So if I do a blood test and I see high levels of MMA and homocysteine, I know I am B12 deficient. Okay. You won't see this with if my problem is folic acid. So if my problem is just folic acid, my B12 should be fine. My MMA and homocysteine will be normal levels because they're being converted like they should be. So I know my B12 is okay. All right. Um, clinical signs and symptoms of folic acid deficiency or B9. We're along with the other signs and symptoms of anemia, I worry about decreased platelets with this one. And so that would increase my risk for bleeding. All right. And then just remember B12 and folic acid deficiency often exist together. Neuro signs and symptoms indicate B12. All right. So patient education, my foods, green leafy veggies, bran, yeast, legumes, nuts, and fortified cereals are good. Know that if you take a folic acid supplement, it likes to turn the urine dark yellow. It's a B vitamin, so we're going to flush what we don't use, okay? Anybody who takes Bs, you're going to get that crazy color of yellow pee. Report signs and symptoms. Again, fatigue, shortness of breath, dizziness, altered level of consciousness, all the same stuff. And then we just want to talk about need for supplementation. Like it's not going to hurt you to supplement. All right, moving on to sickle cell. Sickle cell is crazy interesting. Sickle cell basically takes the red blood cells and turns them into like a half moon shape. All right. Now, what sickle cell does is protect you from malaria. But if my red blood cell is in the shape of a half moon, it can't carry oxygen. It's super fragile. It's going to bust apart. It's not going to be able to squeeze into all the tiny capillaries that I need it to. And because it's no longer this like sleek, round, flexible guy, he is going to clump. And anytime I end up with clumping in the vascular system, I run the risk of a thrombi, right? Or an embolus. So a clot, basically. And when I get a clot, I have an obstruction, I have backup, I end up with ischemia, and it's not good. All right. So there's lots of problems with sickle cell anemia. First of all, your red blood cells are not red blood celling, okay? They're not able to function if they're in the shape of a sickle. So your person, fatigue, pallor, shortness of breath. I'm going to have hypoxia related to low O2. My body is going to be tired because that O2 is going to be deficient throughout. Systemic hypoxia, okay? Um, Vasoocclusion related to thrombi. When you have thrombi, you get pain, swelling, on top of the risk of complete occlusion leading to ischemia. I can have organ damage, delayed wound healing. We call when people, you can get exacerbations of sickle cell, and so we call this a sickle cell crisis. Now, sickle cell is super weird because it can be brought on by like cold temperatures, changes in pressure, like high pressure if you like go up to the mountains or whatever. um let's see, I'm looking for my entire list here, sorry. um Physical, like extreme physical activity, anything like that. um and then on top of all of this, let's go back to the spleen. The spleen is who is in charge of, red blood cells last about 128 days. They cycle through, the spleen takes the damaged ones, normal process, right? We expect to have some normal RBCs. The spleen can handle that. But if you have something like sickle cell anemia, where I have an overabundance of damaged RBCs, my spleen can actually get backed up, right? And then the spleen can't spleen because now it's being overworked, things are backing up, it's not taking care of and producing and doing all the things that it needs to do to keep the body healthy. So the thing with these diseases is you kind of end up with like a trickle down of like, okay, this is what we have going on, but look at all the other things that it ends up negatively impacting to people just in daily functioning, right? And so remember, part of the spleen also aids in immunity. And so if the spleen is not able to spleen, then my immune system runs the risk of not functioning as well. It's not just about the red blood cells, but it affects the white blood cell function as well. So there's a lot of problems with sickle cell. Really, for treatment, we want to minimize complications, minimize organ dysfunction. We want to put my person on O2. Also, with sickle cell, what stands out is I want my person taking in at least 2 to 3 liters of fluid per day. This is going to thin out the blood and it's going to help keep things flushing through. Hopefully, it helps reduce the risk of all that buildup. Okay, all those red blood cells, those damaged red blood cells. If I can keep my person almost overly hydrated, they are going to be able to flush things through. It's going to help the body. Also, a thinner blood is going to be easier for the spleen to process, the kidneys to process, than a thick blood that is just backed up with damaged RBCs. Okay, so that fluids 2 to 3 liters per day, very important related to sickle cell. I worry about my person needing O2 because they don't have enough RBCs to carry that O2, right? Those sickled RBCs can't carry the O2. And sickle cell is very painful for people. The body is used to these cells they're nice, they're round, they flow through, everything works, it's easy. Well, these guys are in the shape of a moon. They don't flow, they clot, they clump, they obstruct. People are in a lot of pain with this. So your person's likely going to be on opioids during an exacerbation. And then on top of that, all the problems with opioids come into play. The constipation, the dependence, all of those things that we talk about. So our assessments, obviously, we worry about our anemia things. They're going to have probably swelling in joints and extremities. They can be jaundiced because the liver is not functioning adequately. It's having a hard time dealing with the damaged RBCs. We may have signs and symptoms of infection, again, because the spleen is impaired and is not able to help with the white blood cells. We're going to look at lab tests. And because this is painful and chronic and debilitating, we worry about psychosocial aspects with this. Nursing and interventions. Administer oxygen. That's going to be one of our priorities, as administering oxygen. And then aggressive hydration, flush out what we can, pain meds, antipyretics, supportive measures, give blood as needed, and blood thinners. Patient education. Here's a great list of our triggers. Cold temps, high altitude, dehydration, overexertion. I worry about infection. I want my person to understand the pathophysiology of this disease so that they understand what is going on. We want to make sure that they are able to maintain their ADLs. If they are pregnant, pregnancy often can exacerbate or reduce the levels of these kind of diseases that we see in people. Autoimmune diseases, you see this as well. It can either exacerbate it or you can actually go into remission. So with pregnancy, we want a lot of education. We worry about fetal complication. If my woman is not getting enough oxygen, imagine what that does to the baby, right? And so you can recommend genetic counseling because you can, sickle cell does have a genetic component to it. All right. Aplastic anemia or hypoplastic anemia. This involves bone marrow depression or damage resulting in pancytopenia. So my cytopenia means a low count, right? The penia part, low count. Pancytopenia means all. Pan means all encompassing, all of it. So pancytopenia, low counts of all of the blood cells, all of them. RBCs, platelets, WBCs, everything is low. So so this is now my signs and symptoms of anemia plus infection plus risk of bleeding. My platelets are low, I'm going to bleed. My WBCs are low, I am at risk for infection. My RBCs are low, I have all the anemia stuff. So diagnostics, CBC, obviously, coag studies, iron levels, and probably a bone marrow biopsy with this to see what the heck is going on. Our treatment, transfusions, possibly a bone marrow transplant. Treatment is going to be based on severity. Some of the meds that we may use, epopoietin alpha, stimulates red blood cells, okay? Stimulates the bone marrow to make RBCs. So epopoietin alpha stimulates the bone marrow to make RBCs. Complications, mortality rate greater than 70%. Like, yeah, right? I mean, all of your blood cells are low. How do you live like that? Obviously decreased cellular and tissue perfusion, hemorrhage. I have low platelets, hemorrhage. And then think about that. If you hemorrhage and you're already low on hemoglobin H and H, now we've complicated that. And then severe infection because of those low WBCs. So it's like the trifecta of horribleness. Aplastic anemia nursing actions, provide supplemental oxygen, blood products, bleeding precautions. We want to protect our person from injury. And then you would think of all the things that we talk about related to preventing infection, right? Don't go out in crowds during flu season. Avoid all of that. Protect yourself. Get your vaccines. Okay, all of those normal things. Patient education. Um, I want to know if my person has a temperature elevation because that could indicate some sort of infection going on. And remember, my person has low WB or low WBCs. Yeah. So like an autoimmune, am I going to respond the way I need to respond to an infection? Probably not. We're going to see almost an autoimmune-like reaction in that it's not as extreme as it should be, right? Because they don't have the capacity to respond as extreme as the body would normally. So I want to know the little signs and symptoms of infection. So any temperature elevation, even if it's below that 100.4, let your physician know. And then like we talked about, avoid injury, signs and symptoms of anemia, and of course, nutrition and supplements. Okay. All right. Thrombocytopenia. This is thrombocytopenia. Penia, again, low count. My thrombocytes are my platelets. Okay. So low platelets. So it's kind of easy. What's my risk? I'm not going to be able to clot. I'm a bleed risk, right? Um, so there's certain things that thrombocytopenia can be related to. We have idiopathic. This can actually be related to viral infections, which is crazy. And sometimes immunizations can bring on thrombocytopenia. It can be medication induced. It can be related to autoimmune disorders. Then we have hemophilia. Hemophilia is specifically related to a factor 8 or factor 9 deficiency. I'm Let's be honest, I'm looking at these Roman numerals and trying to remember what they are. So we have factor 8 and we have factor 9 deficiency there. Um, but it's hemophilia. We worry about bleeding, okay? But this is kind of an intrinsic cause because it's the deficiency of the factors in the clotting cascade. There we go. I'll spit it out eventually. It's fine. And then we can have heparin-induced thrombocytopenia. This is called HIT. This is super weird because it is an immune response to heparin, where the body overreacts. And we know heparin, yeah, it is a blood thinner, right? But in HIT, it results in thrombocytopenia, and so you can just see extreme bleeding with this. So our signs and symptoms with thrombocytopenia, because it's our decreased platelets, our signs and symptoms are going to be things that you see related to increased bleeding. So easy bruising, petechiae, which are those little like pinpricks, red spots, which is little bleeding pieces, portions under the skin. And then just bleeding in general, right? Like nosebleeds for no reason. We worry about gums bleeding, stuff like that. Diagnosis, same old, same old. CBC, coags, bone marrow biopsy. There's going to be some sort of underlying condition. So we want to identify the underlying condition, fix that, replace our clotting factors, DC heparin, DC whatever anticoagulant our person is on. But if they're having a HIT reaction, obviously DC our heparin. And then our complication is always hemorrhage. It's always hemorrhage, right? Makes sense. We're not able to clot. The whole point of platelets is to stop bleeding in an appropriate manner. If I don't have my platelets there, I'm not going to be able to stop bleeding. So nursing interventions, bleeding precautions, right? Minimize bleeding loss. Let's talk about that because it seems like, okay, of course, but is this my person that I want to do like hourly blood draws on? Is this my person that I want to keep restarting an IV on? No, I want to consciously minimize those sorts of things, right? If my person can take PO medications, I'm going to prefer PO medications. I don't want to be giving an IM every 6 hours, right? So so it seems silly to say minimize blood loss because of course, but really think about as nurses how we can do that, right? And then one of the other weirdo ones in here is avoid rectal temperatures. But that's kind of important to talk about because what that's really saying is stuff like rectal temperatures, you can cause mucosa damage, which can result in bleeding. So again, I want to think about how many times do we stick lines and tubes in people and don't really give it a whole lot of thought. But if my person can't clot, I need to be very prudent in what lines and tubes I decide are really, really necessary. Because if I cause a bleed somehow, if I perforate something, there may be no going back for this person. It could be a real problem. So that's why I know it sounds kind of silly, avoid rectal temperatures, but that's why, and that is something as nurses we would have to think about. And then, of course, provide safe environment, um, minimal inflation with blood pressure that can cause damage, which leads to bruising, which is internal bleeding, essentially. So all of those things, okay? Here's just a nice little diagram about bleeding precautions. Think about using an electric razor rather than, actual razor blades. Obviously, no aspirin, small gauge needles. Um, Protect from injury. I worry about brushing my gums too hard. Okay. I don't have any platelets to stop that bleeding. So, soft bristle brush, all of that stuff. Watch out for nosebleeds, watch out for bruising, be cautious, all of that stuff. Imagine having like an active teenage boy who wants to play sports and all of that sort of thing and has a platelet platelet disorder of some sort. Like how horrible would that be to be an active kid, or a girl and you're out there playing sports, doing whatever and you have a bleed risk so you can't we would reduce contact sports, risk of injury, all of that stuff. Box 34-1 is a nice box of bleeding precautions. This is slide 52. So go ahead, take a look at that. Patient education. We want to educate the patient and the family related to bleeding precautions, like what they really need to do um, to not only avoid, but what to do if somebody starts bleeding uncontrollably. Tying a tourniquet, holding pressure, all of that sort of stuff. And then obviously seeking medical help. One of the things on here also is avoiding sexual intercourse when platelet count is below 50,000. Again, we are talking damage to the mucosa. Same idea like we talked about. And then you need to follow up on lab tests. We need to know where those platelets are sitting. All right, so moving on to leukemia. So this is essentially blood cancer, okay? Blood cancer. It's a disorder of the bone marrow, and your WBCs just multiply uncontrollably. They just go crazy. And you would think that that would actually be like a good thing for fighting infections, but they end up not being functional. And because the WBCs are just multiplying like nuts, they end up crowding out the other blood cells. So you actually end up with like low red blood cells, low platelets. So now we have bleeding risk, we have hypoxia risk. And then because these WBCs are not really doing WBC things anymore, my person is at increased risk for infection. Okay. It actually works against the immune system. So there are four major types of leukemia. You don't really need to memorize these. Just know that there are different types, and it depends on what cell we end up seeing. like be the most prevalent and out of control. So sometimes that can determine treatments. ALL is the one we do see most commonly in children. For our signs and symptoms, we're going to get swollen lymph glands. We're going to get our signs and symptoms of infection. Okay? Because again, even though we're making all these WBCs, they are not actually working to fight infection. They're not working as part of the immune system. They're out of control. So if our person is on chemo, if they get any sort of fever, we're going to put them on broad spectrum antibiotics just right off the bat. And remember, those WBCs are crowding out my platelets, my thrombocytes, and my erythrocytes, my RBCs. So we're going to get bleeding and anemia. And then, like with our kind of autoimmune stuff, my person is going to get like flu-like signs and symptoms. They're just, remember, those are just like, you don't feel so good, malaise, just, tiredness, maybe low-grade fever, nothing specific. You just don't feel very great. And also, you can be asymptomatic with this. So that's kind of scary because this could be going on and it can be going on for a while until you end up with any sort of sign and symptom that takes you to get it checked out. All right. For symptoms of leukemia, we use the acronym ANT. So anemia, neutropenia, thrombocytopenia. All right. ANT. Complications: infection, hemorrhage, bleeding, myelosuppression, right? It all makes sense. All the cells, like pancytopenia, remember that? We had low counts of everything, so everything is affected. With leukemia, even though we have a high count of WBCs, remember they're not functioning like healthy WBCs. So you are at risk for all the things again. So my nursing interventions for leukemia, chemo as prescribed, obviously, those prophylactic antibiotics that we talked about, neutropenic precautions. Remember, neutropenic precautions, I am trying not to introduce any infectious agents, any organisms to my person. So that's going to include your person. We're going to wear PPE, including masks around our people. No plants, no flowers. Sometimes some places will still do like the no raw fruit and veggies sort of thing. There's like discussion related to that, but you can still see that. And then we're just going to manage symptoms for our person. Try to keep them safe. Education, neutropenic precautions, anemia signs and symptoms, thrombocytopenia precautions. That's our bleeding precautions, right? And then they're going to be on chemo and potentially radiation. So how to manage all of that, right? Because we all know there's a lot of adverse reactions related to those treatments. And unfortunately, with chemo and radiation, there's always a possibility of sterility. So you do end up having a lot of difficult conversations, with leukemia. It's a big one. This slide 59, box 34.2, these are our neutropenic precautions. All right. So take a look at these. We will probably talk about this in class a little bit further. But you do want to be aware of those. All right, malignant lymphomas. So cancer of the lymphocytes and lymph nodes. Now, remember, when something has traveled to my lymph nodes, I am always worried about it traveling systemically. So if I have a cancer of the lymphocytes and the lymph nodes, my biggest concern is metastasizing to anywhere it wants to go, any organ, right? Because I have just put it into the system and, it's setting it up to travel. So Hodgkin's lymphoma, we see these Reed-Sternberg cells. They are giant lymphocytes. I think I have a picture on the next slide. but they are just giant lymphocytes. They call them RSH, Reed-Sternberg cells, RSH, and they are giant lymphocytes. Now, the thing with Hodgkin's lymphoma is it does have a higher survival rate. All right. So really, if you had to pick between lymphomas, Hodgkin's is the better one. So non-Hodgkin's lymphoma, there tons of subtypes to this. We don't see the Reed-Sternberg cells with non-Hodgkin's. All right, those Reed-Sternberg cells are what differentiate Hodgkin's from non-Hodgkin's. Hodgkin's is specific to Reed-Sternberg cells. Non-Hodgkin's is all the other lymphomas that do not present with those cells. So here's our picture. This giant purple one is an RSH, that giant purple cell. Those other just kind of dark purple cells, those are normal size WBCs. Okay, so you can see the difference there. So what's sad about Hodgkin's lymphoma is we see it in two age groups. Older adults, okay, older adults get everything, but also teenagers. So that, that would be hard. Possible causes, viral infections, and then exposure to chemical agents. Notice that viruses can play a role in these blood-related dysfunctions. Viruses can cause a lot of crazy things. And bleeding blood disorders is one of them. Typically starts in a single lymph node or chain of nodes, and we'll see that what they'll note on pathology is the presence of the Reed-Sternberg cell. So that giant lymphocyte, you'll be able to see that. Spreads predictably. So we know how it's going to travel. It's going to travel through the lymph system. We know where it's going to hit next. We know what it's going to do. The good thing is it's very treatable. Okay, Hodgkin's lymphoma is very treatable. So again, Hodgkin's with its giant lymphocytes is if you have to pick a lymphoma, that's the one you want. Are non-Hodgkin's more common in men and older adults? It can be caused related to gene damage, again, our viruses, autoimmunes, exposure to radiation or toxic chemicals. And if you think about radiation and toxic chemicals as far as employment goes, I mean, still to this day, men are more likely to be working in jobs where radiation, exposure to radiation and or toxic chemicals is probable, especially if you think about like the rest of the world, right? So it makes sense that we might see this more commonly in men related to that. And again, this just encompasses all lymphoid cancers where those Reed-Sternberg cells are not present. What makes this so damaging and hard to treat is that you have erratic spread. With Hodgkin's lymphoma, like we said, we know what it's going to do. We know where it's going to go. So it's easier to attack because I can go, okay, it's going to spread here next. I can proactively get to that spot and treat it before we get there. I can anticipate the how it's going to spread. This, you don't know. It is erratic. So it is much more difficult to treat. Um, and then again, we also list on here exposure to pesticides, insecticides, and dust. So think about where you work. You work on a farm. Maybe you're a bug guy, right? We have a bug guy come to the house. He doesn't wear a mask. I'm like, you are a young man. You are nuts, right? Because all of that puts you at risk. All right, signs and symptoms of lymphoma: painless swelling of lymph nodes, low-grade fevers, unexplained weight loss. When we talk about unexplained weight loss, this is more than 10% in less than 6 months. And you're like not trying to lose the weight, right? You're not on Ozempic, you're not on some crazy diet. right? Unexplained weight loss. You're going to have fatigue. And then the weirdo one is this drenching night sweats. Now, keep in mind, we also see drenching night sweats with tuberculosis. And women, you get to have drenching night sweats with menopause. So, regardless of why you're having drenching night sweats, it's never anything good. Okay? Never anything good. So that is always a red flag. Our diagnosis, again, labs, biopsy, lumbar puncture. Remember, this is floating through the lymph nodes, so we're going to be able to get to the CSF and see what we see, right? Treatment, chemo, radiation. If there's some sort of tumor that we can remove, they can do that. And also, this is where we see our stem cell transplants. And remember, we can use those stem cells. Those are just they're undifferentiated baby cells. So they can go out and grow up to be whatever the body needs them to be. So that's why it's helpful to go and replace those stem cells. Multiple myeloma, this is an incurable B cell disorder. If you remember, our B and T cells are related to uh, the immune system, right? The B cells stay in the bone marrow, T cells travel to the thymus, all of that. They differentiate and fight different things. So this is a B cell disorder. So this is going to be a problem with your immune system. We use the mnemonic of old crab, talking about multiple myeloma. Guess what the old stands for? Old age. Here we go, right? And then crab. Our calcium's going to be elevated, renal failure, anemia, and then bone lytic lesions. Okay, old crab with multiple myeloma. Here's our clinical manifestations. Anemia, so it's the fatigue, the weight loss, or the weakness, sorry about that. Um, blah, blah, blah. Then we're going to have bone pain. You can have paresthesia, which is that tingling, that almost like nerve pain, that tingling in the extremities. We're going to see recurrent infections, B cells, that's your immune system. They're not functioning. So recurrent infections, that makes sense. We're going to throw in that unexplained weight loss, hypercalcemia, renal failure, anemia, and all the signs and symptoms that go along with it. Our diagnosis, labs and biopsy, right? We need to see what's happening. Treatment, bisphosphonates, that's related to the calcium. Remember bisphosphonates grab that calcium out of the blood system and push it back into the bones. We use bisphosphonates for our ladies with osteoporosis because it's going to take that calcium. We supplement with calcium and push it back into the bones. So that's what bisphosphonates do. So it makes sense. Any of our people that have hypercalcemia, remember calcitonin and bisphosphonates are going to be our treatment. Radiation therapy, this is a cancer, that makes sense. DVT prophylaxis, dexamethasone, chemotherapy, right? All the treatments that we kind of expect. Complications, chemo and radiation, our side effects, anemia, bleeding, infection, pathologic fractures. If I have hypercalcemia, fair chance that that calcium is being pulled out of my bones. Well, and if it's floating around in the blood, then it's not being utilized by the blood. Okay. And then you also run into chemo and radiation being hard on the bone structure, and it can weaken the bones, right? So we've got a couple factors in here that are working against us related to bone health. And so what you see are these pathologic fractures where it's not like I didn't fall, my bones are just weak, and you end up with these fractures. Spinal cord compression. Nothing is strong. Everything's kind of compressing in on itself. And then again, we always want to think about that hypercalcemia. And you're going to have to go back to when we talked about electrolytes and what are your signs and symptoms related to hypercalcemia. Remember, calcium is calming, right? We drink a warm glass of milk at night to help us rest because calcium is calming. But if I have too much calcium, remember that's going to put me in this like languid, fatigued state, right? So, because I have too much of it. So you're going to have to go back to electrolytes and look at all those signs and symptoms. Patient education. I want my person to report their fatigue, shortness of breath, dizziness, confusion, sudden onset of severe pain. That could be related to fractures. It could be related to lots of things. Any changes in sensation. There's that paresthesia stuff again, that neuromuscular aspect. That can be related to your hypercalcemia. And instruct on use of non-farm pain management. So we want to be careful because our person can be at risk for bleeding and all sorts of things. So don't ever forget about your NSAIDs and your aspirins related to bleed risk. We always have to think about that. All right, that concludes this about 120 minutes. Yes, that is, no, 1 hour, 20 minutes. There we go. Not 2 hours. Okay. So we will cover the main things in class. Thank you for listening. I will talk to you later.